Imagine getting suspended from school, right? Like losing days of your education, having a permanent disciplinary record attached to your name, all because of your neurobiology. You know, you haven't chosen to be disruptive. Your brain is literally structured differently, but instead of getting a doctor's evaluation, you get a detention slip.
Yeah, it's a harsh reality.
It really is.
Yeah.
And that is the reality for thousands of students right now. So we are taking you right to the heart of an incredibly pressing issue in education and healthcare today. Our source material focuses on an initiative called MentalSpace School, and they are tackling a massive systemic problem. Specifically, the pediatric ADHD equity gap in Georgia.
Oh.
We are going to explore what happens when neurobiology is mistaken for bad behavior, how systemic gaps leave certain students behind, and, well, the practical, on-the-ground solutions currently being rolled out in schools to fix it. Okay, let's unpack this.
Well, to truly understand the solution that these sources present, we first have to understand the core medical definition of the problem at hand. I mean, we cannot accurately discuss an equity gap in diagnosis without first establishing the exact clinical criteria of what is being misdiagnosed in these classrooms.
Right, that is a crucial starting point. Before we look at the systemic failure, let's define the clinical picture. The sources focus specifically on a condition called pediatric ADHD combined type. What exactly does combined type mean in a medical context?
The combined type designation indicates that a child is presenting with two distinct symptom clusters simultaneously. So inattention alongside hyperactivity or impulsivity. It's a dual presentation.
Yeah, okay.
You aren't just seeing a student who struggles to focus quietly, and you aren't just seeing a student who is physically restless. You're observing a complex intersection of both.
Yeah, and the sources list out some very specific clinical features for this dual presentation. We are talking about chronic difficulty sustaining attention on a task, frequent physical fidgeting, habitually interrupting others.
Blurting out answers, too.
Exactly. Blurting out answers before a question is finished, difficulty waiting one's turn in a group setting, and serious challenges with task completion. There is a specific phrase the text uses to describe the physical manifestation of this. Children with this specific presentation of ADHD are often described as climbing or running as if driven by a motor.
That phrase is so telling.
I find that phrase so fascinating because it paints such a vivid, mechanical picture of the brain. If you think about it, a child whose brain is operating as if driven by a motor is basically like a high-performance sports car equipped with faulty brakes.
Oh, that's a good way to look at it.
Right. The energy, the horsepower under the hood is absolutely incredible. But without the ability to steer reliably or hit the brakes when the environment demands it, navigating a strict 25-mile-per-hour school zone becomes incredibly difficult.
Yeah, exactly.
It's not that the car is malicious or trying to cause an accident. It's that the neurological braking system physically isn't engaging.
That analogy perfectly isolates the mechanism of impulsivity, because it is an executive function deficit. The prefrontal cortex, which acts as the brain's braking system, is understimulated. And because we are dealing with brain architecture, the clinical criteria for an official diagnosis are extremely stringent.
Right.
To meet the standards set by the DSM-5, which is the diagnostic manual used by clinicians, these specific symptoms must have been present before the child reached the age of 12.
Which establishes that the condition is developmental rather than a sudden behavioral shift caused by a recent trauma or life event.
Precisely. Furthermore, the symptoms must cause clinically significant impairment in the child's daily life. But here is the most critical piece of the DSM-5 criteria for our discussion regarding schools. The symptoms must occur in 2 or more settings.
Wait, I need to stop you there. Why does the diagnostic manual care about geography? Like if a student is showing all the clinical signs of ADHD in their math class, why does a doctor need to know if it also happens at home or at soccer practice?
This raises an important question about the nature of neurodevelopmental conditions. That specific 2 or more settings rule is the clinician's filter. It is what proves the behavior is a pervasive neurobiological condition rather than a situational reaction.
Oh, I see.
Think about the environmental factors. If a child only struggles to pay attention and acts out in one specific classroom, they might just be reacting to a teacher's poor classroom management style. Or they might be overwhelmed by the sensory input of that specific room.
Or a stressful family dynamic if it only happens at home.
Right, exactly. But if the brakes are truly faulty, as in your sports car analogy, they will fail on every single road the child drives on.
So if the clinical criteria for ADHD combined type are that rigid, and we know exactly what a broken neurological braking system looks like in a medical setting, why are we seeing suspension rates skyrocket for specific demographics instead of treatment rates?
Well, that question shifts us directly from the medical definition into the systemic reality.
The equity gap.
Yeah.
Because the sources state flat out that the equity gap is the part of the ADHD conversation that gets completely overlooked. And the data emerging from Georgia is jarring. Black and Latino students with ADHD are routinely underdiagnosed.
Or even more damaging, misdiagnosed.
Right. Misdiagnosed as having behavior problems instead of a highly treatable neurodevelopmental condition.
The text highlights a deeply ingrained, devastating double standard in how adults interpret the exact same symptoms. The blurting out, the inability to wait a turn, the constant movement, these are objective behaviors.
Yeah.
Yet those exact behaviors earn one demographic population an evaluation referral to a medical professional, while leading to office discipline referrals, detentions, and out-of-school suspensions for another demographic.
So what does this all mean for the student in the moment? I mean, think about how you would react if your child's medical condition was treated as a behavioral infraction. If a child is suspended instead of evaluated, aren't schools essentially punishing a child for their own neurobiology?
What's fascinating here is how implicit bias operates in real time to create that exact scenario. We have to draw a sharp distinction between behavior shaped by environment, meaning a conscious choice, versus behavior driven by neurobiology.
Right, the intent.
Exactly. An executive function deficit often looks identical to willful defiance. A child blurting out an answer because their working memory literally cannot hold onto the thought for another 10 seconds looks exactly like a child blurting out an answer to intentionally disrespect the teacher.
And the adult in the room has to fill in the blank of the student's intent.
And that is where the implicit bias takes the wheel. When a teacher or an administrator looks at a student who is constantly interrupting, their own cultural context and unconscious biases drastically alter how they interpret that symptom.
Wow.
If the authority figure views the disruption through the lens of a medical cry for help, they treat it. If they view it as inherent aggression or disrespect, they punish it.
And the sources outline the staggering costs of this misinterpretation for Black and Latino students in Georgia. We aren't just talking about the temporary frustration of sitting in a principal's office. The sources measure this systemic failure in lost access to evidence-based care, lost academic momentum, decimated self-confidence.
And persistently lost academic trajectories.
Yes. A suspension doesn't teach a child how to regulate their executive function. It just removes the student from the learning environment.
Which initiates a catastrophic feedback loop. The student misses instruction, falls further behind academically, experiences higher levels of frustration and shame upon returning, which then exacerbates the very behavioral symptoms that got them suspended in the first place.
It's awful.
Treating a neurobiological condition with punitive discipline is a categorical failure of intervention.
So the systemic failure is obvious, and the devastating costs to these students are clear. How do we actually correct the course? Because clearly, just lecturing teachers about implicit bias isn't a medical intervention. What does the actual evidence-based treatment for this look like when a student is finally correctly identified?
Well, the standard of care, according to the clinical sources, is multimodal treatment. It is an integrated system of simultaneous supports.
I want to push back on that for a second. If we just establish that this is a neurobiological issue, like if the literal brain chemistry is causing the faulty brakes, why isn't a medical prescription enough? Doesn't the right medication just fix the braking system? Why do we need multiple modes of intervention?
That's a common misconception, actually, because pills do not teach skills.
Ah, I like that.
Yeah, medication can optimize the brain chemistry. It can provide the dopamine necessary for the prefrontal cortex to engage the brakes. But the student still has to learn how to drive the car.
Okay, that makes sense.
That is why the text breaks the multimodal approach down into several distinct categories that must operate together. First, you have behavioral therapy. This often includes parent training and behavior management and direct organizational skills training for the student.
Which is actively teaching the child how to manage their environment.
Yes. And then you add classroom accommodations. The sources list preferential seating to minimize distractions, frequent scheduled movement breaks, and breaking down large task instructions into smaller steps.
I see how that directly addresses the clinical features we discussed earlier. If a child has chronic difficulty sustaining attention on a massive week-long project, breaking that project down into 5 immediate, bite-sized tasks provides the urgency their brain needs to engage.
Absolutely.
And if they are driven by a motor, a scheduled movement break prevents the engine from overheating and disrupting the class.
The sources also point to executive function coaching, and when prescribed by a licensed clinician, medication, which can be either stimulant or non-stimulant.
It's like a three-legged stool, or maybe repairing a house with a cracked foundation. The medication is the new concrete pouring in to stabilize the base. But you still need to erect scaffolding around the entire house. That's the behavioral therapy and the classroom accommodations.
Exactly.
You need that scaffolding to keep the structure standing while the new concrete cures and the student learns to support themselves. If a school denies the accommodations because they still view the ADHD as bad behavior, they're essentially ripping the scaffolding down and watching the house collapse.
That is the exact mechanism of multimodal care. You need the scaffolding. But the sources highlight one more element that is absolutely critical to this treatment blueprint, and it directly addresses the equity gap. That element is culturally competent evaluation.
The sources emphasize this heavily. Clinicians must account for a student's cultural context and primary language.
Having culturally competent clinicians is not just some progressive bonus feature for a health clinic, it is a strict clinical necessity.
Because of the intent we talked about earlier.
Right. If the entire core of diagnosing ADHD rests on distinguishing between a conscious environmental behavior and an unconscious neurobiological symptom, a clinician who does not understand a student's cultural background or home environment cannot make an accurate medical assessment.
They will just misinterpret the behavioral data.
Exactly. Culturally competent evaluation is the only valid way to ensure the root cause is accurately identified.
This all sounds completely logical in a research paper, but how does a massive, underfunded, overburdened school system actually build that kind of scaffolding? That brings us to the actual on-the-ground implementation. We've explored the diagnostic criteria, the systemic equity gaps, and the necessity of multimodal care. Now, let's look at how this is actively being deployed to solve the problem for students in Georgia right now. Let's look at MentalSpace School.
This is where we see theoretical clinical models transition into tangible infrastructure. MentalSpace School is providing comprehensive K-12 mental health support specifically integrated into Georgia schools.
And their model is engineered to attack every single bottleneck we just discussed.
Yes, exactly.
The scale of their offerings is massive. They provide same-day therapy evaluations and ongoing treatment. They assign dedicated therapist teams to each individual school.
Which builds consistent relationships.
Right. They offer crisis intervention, suicide and violence prevention programs, staff wellness initiatives, and family counseling. And directly addressing the clinical necessity you just outlined, their licensed therapists are culturally diverse by design.
Now, that is the structural mechanism used to ensure culturally competent evaluations. You cannot retrofit cultural competence. You have to build a diverse clinical team from the ground up so that the professionals evaluating these students actually reflect the communities they serve.
That makes a lot of sense.
But the logistical support MentalSpace School provides to the districts is just as vital as the clinical support.
Yeah, let's talk about those logistics, because schools are dealing with massive regulatory burdens when it comes to healthcare. The sources note that MentalSpace handles the heavy lifting of medical privacy laws, like APEA.
And educational record privacy regulations, like FERPA.
Right, but here's where it gets really interesting. They specifically offer compliance support for a Georgia legislative mandate known as HB 268, which hits a critical deadline in July 2026.
If we connect this to the bigger picture of education policy, that HB 268 deadline is a massive catalyst for school leaders. It is a legislative mandate forcing schools to establish concrete mental health infrastructures and wraparound services.
So it's not optional anymore.
Exactly. It means this level of care is no longer just an ideal goal for a forward-thinking school district. It is an urgent legal requirement. MentalSpace School is stepping in to provide the exact blueprint districts need to comply.
And they are simultaneously dismantling the financial barriers to entry, which we know is the other half of the equity gap. Instead of forcing parents to navigate a labyrinth of out-of-network costs, MentalSpace School has built an infrastructure that accepts a wide array of major commercial insurances.
Like Blue Cross Blue Shield, Cigna, Aetna, United Healthcare.
Humana, Peach State, CareSource, and AmeriGroup. But here is the piece that actually changes the game for historically marginalized families. For students on Medicaid, the cost is strictly $0.
We need to analyze how those two specific details, same-day teletherapy and $0 Medicaid function, as the exact mechanisms dismantling the systemic equity gap.
Walk us through that. How does eliminating that friction actually change a student's reality?
Well, think about the traditional path a marginalized family faces when a child is struggling. To get a diagnosis, a parent has to take unpaid time off work, find an in-network pediatric specialist who likely has a 6 to 8 month wait list,
Oh, wow, yeah.
and then secure reliable transportation to a clinic across town and pay a specialist copay they might not be able to afford. For many families, that logistical mountain is literally impossible to climb.
So the child goes undiagnosed, the unmanaged symptoms continue, the school suspends them, and the academic trajectory is lost.
Exactly. But with this model, the barrier to entry is vaporized. Same-day teletherapy means the evaluation happens immediately inside the safety of the school setting or at home.
And the $0 Medicaid policy means all financial friction is eliminated.
Yes. Suddenly, that Black or Latino student who would have been sent to the principal's office and suspended is instead instantly connected to a culturally competent clinician. That clinician recognizes the neurobiology, prescribes the multimodal scaffolding, and alters the trajectory of that child's life.
And the outcomes they are seeing completely validate the model. I mean, the sources reveal the data on MentalSpace schools' impact in the districts they serve. An 89% improvement in student attendance,
That is huge.
a 92% reduction in anxiety, and an 85% family satisfaction rate.
Those numbers are not just administrative victories. They represent a fundamental shift in student well-being. An 89% improvement in attendance means students are actually staying in the building.
Receiving vital academic instruction rather than sitting at home on a disciplinary suspension.
It proves a core medical principle. When you treat the root cause of an issue, the secondary symptoms like chronic absenteeism and severe anxiety naturally plummet.
It is absolute proof of concept. The scaffolding works. For anyone listening who wants to explore this model further, whether you are looking to bring this infrastructure to your own district or simply want to understand the methodology, the sources provide their direct contact info. You can dive deeper at mentalspaceschool.com or reach out to their team at mentalspaceschool@cheaptherapy.com.
It is incredibly compelling to see theory put into practice. It serves as a masterclass in how to bridge the massive gap between advanced medical knowledge and practical systemic application.
Which brings us to the end of today's deep dive. Whether you are an educator trying to manage a complex classroom, a parent tirelessly advocating for your child, or just someone who cares deeply about fairness and equity in our healthcare systems, these sources reveal something profound.
They really do.
Removing the logistical and cultural barriers to mental health doesn't just satisfy a legislative mandate, it fundamentally rescues human potential. Treating the root neurobiological cause with culturally competent care is exponentially more effective and more humane than punishing a symptom the child cannot control.
It always goes back to the sports car.
Yeah, you don't punish the car for having faulty brakes, you fix the brakes, and you teach the driver how to navigate the road.
This raises an important final question to consider as we close, drawing strictly on the contrast we've explored today between environmental behavior and neurobiology. If culturally competent evaluations are continually proving that so much of a child's so-called disruptive action is actually driven by neurobiology rather than a conscious choice, how many of our standard disciplinary systems in schools today are currently built on a fundamental misunderstanding of the human brain?
That is a heavy, necessary thought to sit with, because if the equation we are using in the classroom is based on a misunderstanding of the variables, the answer will always be wrong. Thank you for taking this deep dive with us today. We'll catch you on the next one.